You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Okay, so secondary prevention and elevated LPA. So this is a 50-year-old gentleman with a family history of premature ASCVD. He developed chest pain with exertion playing pickleball. I've been playing pickleball with my wife. I'm wondering if this is going to be me one day. Leading to stress testing and cardiac catheterization with a stent to the LAD and left circumflex, hypertension, referred by a primary care clinician to a lipidologist for evaluation of dyslipidemia. Patient smokes, went out with friends at night, only a couple of times a week, 1 to 2 cigarettes. They call it social smoking. Medical history, untreated dyslipidemia for 20 or more years. Rosuvastatin started 3 years ago at the time of the first event. Current visit, the LDL is 130 and the LPA is 130 nanomoles per liter. The highest prior LDL was 220 milligrams per deciliter. So current guidance has been to focus on exercise, heart-healthy diet, and behavior modification. So the patient's rosuvastatin was increased to 40 milligrams with addition of ezetimibe 10. Diet and lifestyle was reinforced, referral to a registered dietitian nutritionist, and now the LDL is 99, and the LPA is 140 milligrams per deciliter. So the question is, what would you do next? So add a PCSK9 monoclonal, add inclisiran, add bempedoic acid, reinforce diet and lifestyle with no additional medications, or enroll the patient in an LPA-lowering trial. Okay. It seems that most people want to add a PCSK9 monoclonal. Should we stop and have a discussion here, or how do you want me to proceed?
Yeah. I mean, you can show your answer.
Yeah, so I think that's reasonable, and we've talked about it a lot already. The patient needs additional LDL lowering. And this is one of those examples, I think, where you don't want to become distracted from the prize. The prize right now is that lowering LDL is a good thing, especially in a high-risk patient like this, whose risk is even enhanced by his LPA. So continue to lower LDL. And yes, the LPA is high, and choosing a PCSK9 inhibitor might also lower the LPA, but I think that makes the most sense. I don't know if you have any other thoughts here.
Yeah, I completely agree. This is a patient with very high-risk ASCVD, baseline severe hypercholesterolemia. The baseline LDL is over 190. The LPA further supports aggressive treatment. So I would be going to an LDL below 55. The lower, the better. If you're starting at 99, PCSK9 would get you maybe to around 40. Inclisiran would be a little bit less. Bempedoic acid would be substantially less, only getting you down to an LDL of, I don't know, maybe like high 70s, 80. And then, of course, diet and lifestyle are the foundation of treatment, but that's not going to be the key next intervention here. And I wouldn't view LPA lowering trial as mutually exclusive necessarily. It would be a reasonable thing to do, but the key next clinical step is A.
How about social smoking?
I think that's an important thing.
I mean, social smoking.
All right, I love it. And this patient was a fabrication of a lot of my friends, okay? And I am amazed that they do this.
Yeah.
This is what grown-ups in New York City are doing.
It seems to be a particularly nasty combination, smoking and LPA. So I definitely would get rid of that.
Is it possible that the patient would qualify for an LP? Is the LP too low to qualify?
That's a good point. Yeah. It's on the low side for the trials.
Yeah, I think they're 175 to 200, right?
Yeah.
And the age is usually 55. That's around where it is. Actually, no, some of them are younger. They're 18 and up.
So the LP(a) was how high?
140.
140.
140? Yeah. It's interesting. Yeah.
Okay.
If it was close, and I've seen this happen in some of the trials I'm involved in. hold off on what you're thinking of doing, put them in the trial. Hopefully they'll get the active drug versus placebo, and then just add,
Yeah.
the other thing that they're needing.
Yeah. In this case, if they start the PCSK9 and get the 25% reduction on average, then they'll end up being in they may even drop below that 125. They likely would drop below the 125 point for an animal's plea.
So I put this up there just to remind everyone that in the 2018 guidelines, the recommendation is to use a PCSK9 inhibitor in patients with ASCVD who are at very high risk of ASCVD events, which turns out to be about 90% of patients with ASCVD. So if you're not sure and you guess and you don't want to go through this list of requirements, 9 out of 10 times you'll be right. That's what I tell my house staff. But 2 or more major ASCVD events on the left, or one of those, and then 2 or more of those high-risk conditions. And the key to remember about the high-risk conditions is they may not have been high-risk last year, but now suddenly they show up and they're 65. Or suddenly their EGFR went from normal to a little abnormal. So you have to always constantly go back and looking at this. But in a patient like this, I would tell you, I wouldn't even bother doing this anymore. If they had a high LPA, I would be aggressive with the PCSK9 inhibitor.
I'd show your friends this slide, current smoking.
Yeah.
I mean, smoking is smoking.
Yeah, this is the ACC guidance that we talked about. This is, again, why would a clinician measure LPA? We've talked about this already. But I do think people often ask me, do you get this question? What about LPA genetic testing?
Mm-hmm. Right. And I say not useful because the blood levels are more than 90% genetically determined. There's not really a need to do it. Although our clinic does genetic testing in patients with suspected familial hypercholesterolemia. We do not do it for LPA.
Right. There was one study looking at a couple of LPA mutations that seemed to respond better to aspirin therapy. And so I've had smart patients come in and ask me, should I do the genetic testing to see if I respond? And it reminds me of the genetic testing that they used to do for responding to statins.
Right.
These are population-based databases.
Right.
And so you can't apply this kind of genetic analysis to individual genetic testing and expect to see a response. Yeah. You just have to remember that. So we went through the agents already. PCSK9 inhibitors, the statins will make it go up. One question might be with a patient like this, oh, do you think my LPA was elevated because I was on a statin when you measured it? I wouldn't stop the statin to find out in a patient like this.
Right.
It's a good question, right? Yeah. But the answer is probably not enough to make a difference, right? I told you it's about 15% at max. That's not going to change his LPA clinically, I don't think.
It is interesting, though, that you could although apheresis is very effective acutely, the time average, as it notes, is 35%. So you could potentially outdo that if you go down on the statin dose and up on and add a PCSK9 inhibitor. Yeah, due to the time average results.
Well, that is interesting. I mentioned inclisiran. Its effect on LPA is not quite as robust as it is with the PCSK9 monoclonals. This was the statin analysis for LPA that I talked about, so I don't think we need to kind of revisit this again. LDL and LPA lowering, I mentioned that the effect seems to be independent, and the effect of risk from LPA is significantly greater on a unit measured metric than ApoB. And risk assessment, I think there are a bunch of different ways you can do this, but in the back of your mind right now, just remember that it is going to increase risk. Patients with LPA levels greater than the 99th percentile in this particular analysis had an odds ratio of 3.4 for an MI and 2.6 for ASCVD compared with patients who had a lower LDL. So when patients ask you, what's my risk because my LPA is elevated, I give them a number somewhere between 2 and 4 at times. I don't know what you tell your patients.
Yeah, I agree. That's very reasonable.
Yeah, I try not to use percentages. I try to say it's double or it's 4 times greater. I find that's but I think that's a number you can use if someone asks you. And that data is kind of good. I showed you this already about LPA lowering. And so the conclusion, the patient was started on a PCSK9 monoclonal. On repeat labs, the LPA went to 110, but the LDL is now 45. So I think just getting that LDL below 45 is the best part of this. And you happen to also get some LPA lowering, which I showed you. It's a log linear event kind of line. So I think you may have done some benefit here. I wrote it may or may not impact it, but also you want to screen the family members.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.